Welcome to Dive into Health MD, the podcast where we explore how everyday habits shape your physical, cognitive, and financial well-being. Through conversations with physicians, scientists, and farmers, we explore how daily choices like food, movement, sleep, and mindset shape the health and life we experience, with special episodes on sourcing high-quality food ingredients. We do our best to stay up to date, and we're always open to refining our thinking as new knowledge emerges. I'm your host, Dr. Akshita Mehta. Let's dive in.
Okay, so I think we told you a little bit about it already, but basically, this segment of the podcast, the physician segment, where we bring a bunch of physicians on, is really just to talk about your practice, kind of like your bread and butter stuff that you see every day, and if there's anything that you think people should know about whatever it is that you see, anything that people can do to mitigate some of the disease that we see, but even not, just really shedding light into what physicians do and kind of what our day to day looks like. So cool, Neil, excited to have you on.
Yeah.
So we open each of these with a little bit of an icebreaker question. So the icebreaker question is: health is built in choices that we make every day. If someone followed you around for the day, what would surprise them most?
I would say the variety of people that I see on a daily basis. I think when I had my first job in Washington State, I worked at I'm a pain management doctor. I worked at a pain clinic in like an upper end suburb. And so I felt like I saw the same generic type of people. Gone into the car accident space and meeting people who don't have insurance from a much lower socioeconomic background. I can equate it to working at Penn Radnor versus West Philadelphia, or just kind of the difference there. And so I think the variety of people and just the amount of languages and cultures that I see, I think would really surprise people.
Nice. Awesome. Cool. Well, yeah, just kind of rolling right into it. Can you tell us a little bit about who you are and what you do?
Yeah, so my name is Neil Batta, and I am a physical medicine and rehab doctor, and I have a pain management fellowship. But what that really means is I do a lot of injections, I deal with a lot of musculoskeletal disorders, and I work at a practice now that exclusively deals in personal injury. So patients who have any kind of slip and fall injury, car accident, slip and fall injuries are actually covered under your car accident claim. And then either they're using money from their car insurance, which has a set amount, or they're using money from a third party if they're not at fault. So somebody else is paying for their care. Or if they don't have insurance and there's a certain amount of money, or they can use a settlement. If they have money from a settlement, they can use it towards treatment. And so our practice was started by chiropractors and also an orthopedic surgeon in Utah. And his wife's actually an attorney as well. So they came up with this model and kind of this niche area. And when I say niche, it was probably niche 7-8 years ago. But as health insurance and payments have gotten less in pain management per procedure, people have been trying to figure out, well, how can we kind of maximize our dollar value? How can we help patients? And kind of the workers' comp cases and like LNI, MVA, all these kind of the payments are still pretty solid for what we do. So I think a lot of people or physicians in my space are at least doing some of this type of work. But I just took the leap and do it full time.
Awesome. Okay, so let's like dissect that a little bit more. So what kinds of complaints, I guess, are patients coming to you with?
Yeah, so I'll start at the top. So let's say somebody has a car accident. They're going to be plugged in with an attorney. They're going to be seeing a chiropractor. And let's say their neck pain, their headaches, concussion symptoms aren't getting better. They may get a referral to our clinic, at which point we'll do an initial evaluation and we'll talk about the full accident details. Were you restrained, unrestrained? What was the mechanism of the accident? Can you describe, did you hit your head, lose consciousness? Did you go to the emergency room? Do we have records? What did you get done? What imaging have you had done? And essentially going through each area of the body, going through headache, concussion symptoms, cognitive symptoms, vision complaints, tinnitus in the ears, neck pain. Does the neck pain go down the arm? Qualities of the pain symptoms, and then really any other complaints, knee, shoulder, ankle, really anything and everything. And we try to piece together what we can do, keeping in mind that we have a limited financial pool for what we can actually order. MRIs cost a certain amount of money. Injections cost a certain amount of money. And so we want to try to work within the finances, but also figure out, well, what can we do to help patients? So Our practice has MRI centers associated. We have x-rays, and we use these tools to also help patients. In addition, we have diagnostic concussion testing, going through balance testing, wavy EEG testing for concussion, and we have tools in that regard as well.
Wait, that kind of blows my mind, actually. I'm so used to, I mean, I'm ER, obviously, so I never think about cost at all. Do you know how much money you have to play with before you can order? Like, is the insurance company telling you ahead of time?
That's a great question. So, yes and no, it's both. So, a lot of times when we get referrals from attorneys, we don't have all the information because things aren't settled yet. So, we take payments on liens. So, we're taking a promise of payment, but we may not see that money for a few years down the line once the case is settled. If the case goes to trial, right? We don't know. We may be called to the stand. Our records may be used in the court case, and that may help advocate a patient. Now, it's different because we're working kind of with the attorneys to advocate for a patient versus adversarial when sometimes attorneys will litigate a physician for not meeting standard of care or whatever the case is. So it's sometimes we know, and if we know, then we have a select pool. But think of it like this, Divya. It's a big pie and everybody takes from the same pie. So the chiropractor is taking from that pie. The imaging is taking from the pie. The ER is taking from that pie, right? When you're seeing a car accident, you're asking immediately, what is your insurance number? What is all that? Because everybody's pulling from the same pie. And so I believe in Washington State, and every state's different. So I want to just speak for Washington State because that's where I work, is a $25,000 PIP. So for your personal injury. Now, if the other person hits you and they're uninsured, then it's up to $100,000. And then depending on what is settled and all of that, then that money can be way higher. So I had, like, if there's an assault case or something like really crazy and there's a big settlement, then we see all this. But we're trained at this practice to treat the patient medically. Don't worry about, like, if you think an MRI is needed, get an MRI. But the difference is I don't have to talk to an insurance company to get the MRI. I don't have to have, you got to do PT for 6 weeks. You have to be able to move in this and X and X and X and X. I don't have a check box. I just say MRI and MRI is done.
But
and
then
then
what
later,
if you end up overcharging or
What
like,
if you bust?
yeah.
right. It's again, you just have to know, you have to really be able to justify why you're ordering certain things. And so I think that comes on to still trying to meet standard of care, but I think it's just a different mentality. Like, it's almost like a health insurance is like, it's like jail. Like, you just feel like you're chained here. But I think as I've worked in this space, I feel more free. I feel like, okay, do I really need, like, is it going to change my management if I get this MRI? What is it going to tell me about this case? Is it going to make any difference? Right. And so I'm allowed to kind of think in this space. So I almost think I used to, even in the health insurance, maybe order too many MRIs. Now I'm realizing, okay, and I've kind of learned in the last 2 years from the job, okay, maybe I don't need that MRI right now. Maybe we can try this type of injection first. Maybe these views and x-rays can help me, or maybe an x-ray doesn't even help me at all. It's just, I just need to use my clinical exam and things. And so I think it's changed the way I think about all of that. So yeah, it's a great question. I guess I probably order less than I did before.
Interesting. So you have more freedom almost now, but really needing to justify the utilization, you actually order less.
Yes, I think so. Because you really want to think about it, and you want to think, can I help the patient? Now there's a flip side. There's also the side of like a forensic side, right? You want to identify something to maybe add value to a case. So let's say that MRI may identify that this situation is surgical. Does it mean the patient has to have surgery? It's their decision. But if it's surgical, well, the case has higher value. And the case has higher value, then the referring attorneys there understand that. They're looking at it from that perspective. Then the chiropractors, okay, they're the ones who are pretty much the primary attendings on the case. So they like it too. So we want to also add value as well as care for the patient. So there's like the kind of that forensic side to it that is also a little.
Wow, this is so different than like typical medicine, actually, in so many ways.
Mm-hmm. Yeah,
I didn't know this about your practice.
Yeah, no, it's cool. I mean, they do a lot of. We have offices all over the state. Now the surgery side. So we have two sides to the practice. Our side, post injury, is the pain management side. So we We have our non-surgical space, and then there's the OSIC, orthopedic surgery, like consults, and they have the surgery side. But a lot of surgeons, they work at their practices and they do like a side hustle with the surgery because the payment is so good. Like it's so good on the dollar. So these shoulder surgeons are like, yeah, they're doing all the operations, replacements, all that stuff under Medicare or whatever. And then they come here and then they actually, they do cases here as well, but they do it part-time. So we have surgeons, but they're not working like full-time. So we have hand surgery, shoulder surgery, knee, hip, multiple spine surgeons who work with the group.
Does that mean you're the one that's doing all the referrals to the surgeons? Like they can't get into these surgeons without you referring them?
Good question. They can get referred directly to the OSIC team, or they can get referred from us. Even though we're in the same building, we kind of operate as two separate entities. So just depending on if the finances make sense. So sometimes if a patient's going to be seen by a surgeon, they want to make sure there's enough money in the pot for them to do surgery. Spine surgery costs like $100,000. So they're not going to do a fusion if there's $5,000 in the case. Then it's going to say, okay, you got to use your health insurance, or you got to be linked up with your primary care provider. So the
Oh, that's so tricky.
sense for the surgeon to actually evaluate. So it's a little different. And sometimes if we're in a situation where, look, it doesn't really matter what the finances are, like this case is surgical and it just needs to be evaluated, then we have to send them to the community and we try to help with the transition of care.
Yeah, okay. Because I was going to say the ethics of that also gets a little bit murky. Like if you are like, oh man, I'm seeing that you really need something, but you can't afford it with your insurance. Like how do you even navigate that ethically?
I guess it's like just thinking about it systematically, right? As our insurance changes in the US, so many people now are on Medicaid. People are losing coverage. This is a nationwide issue. And not even more specific, with us. I think the payments and the medicine are extraordinarily high. But yeah, and I think a lot of patients I see don't have primary care doctors. They've never seen a doctor. They don't have access to the specialty care we provide unless they get into an accident. So a lot of patients I see, like these Somalians, Ethiopians, I saw a Marshallese Island patient. I mean, just people from really all over the place, and they've never seen a doctor ever. So I'm like, oh, wait. So if there's something going on, we have to try to say, okay, these are community resources. These are things you can go to just to try to help. But it's very imperfect because really the healthcare system abroad it's tough for people to get into primary care.
Yeah, but at least it sounds like there is at least an option to decompress. So like if a patient really does need something, right, but it's not financially falling into whatever pie is allotted for them, then at least like referral to somewhere outside of the system is an option.
Absolutely. And the nice thing is we're at least able to identify it for the patient. Look, this is going on, this is surgical. And then it gets even more tricky, like what is really at fault? So I'll give you an example. We have a shoulder MRI. The shoulder MRI shows, partial tear of a rotator cuff, supraspinatus, right? You see those all the time, your shoulder MRIs, actually. And let's say then the patient comes in, but they're a metal worker, they're a construction worker, they've been lifting their shoulder their whole life. I mean, how do we really know that this partial tear is from the accident, or is it from just they had it before and now it's just symptomatic after the accident? So we also have this idea of, okay, we know that this situation could be surgical, but how much is actually attributed to the accident? So it's up to us to also be able to justify, okay, like we can actually cover treatment under this, or was it something that was pre-existing and aggravated before? And so it's a lot of that kind of thinking as well.
Interesting. Mm-hmm. Dude, that's so fascinating. How is that different than your old practice in cover?
I feel like I can just do what I need to do to treat a patient. I feel like I can say, look, you have a partial, let's do PRP. Great, PRP is covered under MVA claim. No questions. Really helps patients with partial tears. Better than steroid. We can use ultrasound. So I can actually just do, the difference is I can say, oh, I want to help you.
Wait, this is going to be a slight off topic, but PRP. Do we believe in PRP?
I wasn't a believer before, but I'm 100%. I am a believer now. And I say that in the most, I had almost zero belief in PRP before I came to this practice. I was like, okay, yeah, sure.
Wait, any joint, PRP.
I would put it anywhere. Hair regrowth. I would PRP the entire body. It's just PRP.
Okay, can you back up and just explain why you think this works?
Okay. Well, one is I think the safety of PRP is very good. I think we've established it's your own plasma, right? And you look at risk factors, right? Are they on anticoagulation, Xarelto, things like that? And it's funny, even when patients on the anticoagulation, There's some studies that kind of vaguely say that it actually still works. I mean, it may just be less effective. But things like Coumadin, Xarelto, aspirins, ticagrelor, Plavix, you want to make sure, because they really ideally for PRP, you want to make sure that the blood cells are good quality. So if they have certain types of leukemias or things, you want to make sure that it doesn't impact the platelets before you spin the cells or certain blood thinners. So if you can establish that the PRP will be reasonable quality in most healthy patients of all ages, you'll likely have success. And then what are you trying to target, right?
So just to that point in and of itself, like intrahuman difference makes it different. Like, can you guarantee that this PRP is the same as my PRP would be the same as Akshida's PRP is the same as your PRP?
You can't. Yeah, it's a great question. You can't guarantee it. I think that's the thing about any of this spine injection. You just can't guarantee. But what I can say is like it'll be safe. The risk is pretty reasonable. I've surprisingly effective in like older patients. I have like 70, 80-year-olds who have cervical facet pain. I do a diagnostic injection. So what we do with facet pain for the audience is we'll do a diagnostic test injection where we'll put numbing agent across the joints under x-ray anywhere in the spine. And we identify, do you have relief after the numbing agent? If we've been able to identify what joints via that procedure, then we can put PRP into the joints under x-ray. And so I've had older patients who have a myriad of health problems, 90% relief from the procedure. And I can't explain it. I'm like, wait, isn't your PRP supposed to be bad? But no, it's good.
Wait, can you explain what is PRP? Can you just like define that first? And then let's talk about like spine pain and like what a facet joint is.
Okay. So I'll back this up. So spine pain comes in.
Oh, what is PRP? We've been talking about that, yes. But for someone who doesn't know what that is, what is that?
So PRP is platelet-rich plasma. And platelet-rich plasma involves doing a blood draw. So we take blood from an IV draw and we spin the blood in a centrifuge for 9 minutes. Well, different types of spins. Well, we do 9-minute spin for different types of PRP depending on the cell count. But to simplify it, we spin the blood down in a centrifuge and we extract different layers. One of the layers is the plasma layer without the red blood cells. So we want to separate out the red blood cells. Then we extract the plasma from the centrifuge tube. We pull it out, we extract the plasma sterilely without the red blood cells that are all separated out. And then we have that sterilely in a tube. And then we inject that plasma into a joint. Now, there's different types of regenerative medicine. PRP is what's called an indirect regenerative medicine, meaning it does not have growth factors in it. It recruits your body's growth factors to come to the region where it has been injected, versus things like bone marrow aspirate, where bone marrow aspirate is another type of regenerative where your iliac crest, which is on the side of your hip, you take a trocar and you essentially grind it into the iliac crest, into the bone marrow. You pull out the bone marrow. You spin that down in a centrifuge. That concentrate actually has growth factors in it. So that's a direct therapy versus PRP is an indirect therapy. And my understanding in the US is you have to use your own cells during these therapies. In Europe, you can use cells from other sources and inject them into yourself. So they're a little more advanced into what the world, like where this is going. But PRP has a lot of uses and it's used in like beauty, kind of like hair regrowth space. It's used in the joint pain, and we'll get more into that. I actually have a lot of other things about back pain I want to talk about, but it's the joint pain space. It's used in sexual dysfunction, erectile dysfunction, also in females as well. And I've heard this anecdotally from surgeons, but also there is evidence to say that it does help. And so there's a lot of resources. I have a dermatologist.
But this is my question always, because like whenever I look at the data, like to be fair, I have not done a deep dive by any means, but I kind of thought the only data that showed that it was maybe valuable, not even convincingly valuable, was just knee osteoarthritis. And like every other joint you inject PRP into was kind of like
I think this also depends on like everything that you and I talk about is like the nuance, right? When it comes to like studies and the details. And so like I haven't had that many conversations about PRP, but like one of the ones that I had was with a plastic surgeon, right? And he was basically saying not all PRP is the same, right? It depends on how you spin it down. It depends on how long that process is. It depends on so many factors that like you could get a PRP injection and it could have no effect, but you could do the same injection under different circumstances and it could. So it also depends on what's the depth that is being injected, right? And there were like all of these different things that he talked about because he used PRP in his practice, but he was like, these things are, you can't just blanket statement say like use PRP as a treatment without describing like how and all of the details. And I think he even talked about like the gauge of whatever was going on. But yeah, so I think there's so much more in it, right? Like, so maybe there is some evidence about knee osteoarthritis and then maybe someone else in a shoulder, but like, how did you actually do it? And I think that's where like the devil's in the details a little bit.
I completely agree. And I like that phrase you use, devil in the details. One of the surgeons I work with loves that phrase. So I think I completely agree with everything you said. We use Regenex. I have by the way, no financial disclosures here. I get no, these are different brands. So Regenex is one, Arthrex is another we've used, but completely to your point. Why are there different chargers for PRP? Why is
Wait,
one?
why is there even a brand? It's the
Yeah,
patient's
we're
own
just taking
plasma.
someone's blood, right?
Yeah,
Like,
so
what's the brand here?
it's the kit that comes in. So the kits
Oh,
or the centrifuge actual machine is from
okay.
different companies. But as the years have gone by, they become like more equivalent. Like they kind of copy each other. Like Medtronic, Boston Scientific, they all kind of merge and say, oh yeah, our technology is better than yours, but really pretty equivalent. And I think we found more that brands are catching up to each other. And I talk with some of the PRP reps and they're pretty confident to say, look, and there it's like we talk to like a distributor and then he talks to the company, so it's kind of like there's this whole like thing of PRP now and this whole world of people trying to sell you these products. And so it's how much spend, what quality. So I'll give you an example of to take your step further actually. So epidural injection. So back pain, we can do injections into nerve roots for our audience, sometimes called an epidural injection, where these nerve roots are held. The thought is we used to put steroid into this space primarily, local anesthetic and steroid, numbing agent and steroid. The thought is, can we put PRP, platelet-rich plasma, into this space? And studies that have come out, they're doing like double and triple spins to improve the quality and all of that. But is that realistic in practice to spend, 45 minutes spinning this down? And so to your point, like, does that study, do we trust the results? Like, can we replicate it in clinical practice? And so I think the jury's still out on all the uses it can have and truly what it can have. But I'm of the firm believer that in a decade, we're going to look back and say, we did way too much steroid. I think we're going to be doing PRP in the epidural space. I think we're going to be doing PRP. Divya, to your point, for the joint pain in the neck, the facet pain, there are articles to say that it's pretty equivalent to radiofrequency ablation. Like it has pretty good benefit with the facet. So the joint pain in the neck and back, I think it's gaining popularity.
But so if your point is that all PRP injections are like technique dependent, really?
Yeah.
Have you, or are you able to, if you haven't, like been able to look at your own patient data and be like, okay, of all of the PRP injections I've given, X percentage actually have a benefit with my specific technique?
That's a great question. I've never looked at my data, but I can just tell you that it's an abnormality if somebody doesn't have really good benefit. It actually sticks out to me. They didn't have relief. What?
Wow.
Like
That's
that.
like...
It actually like shocks me when somebody doesn't have relief from.
Yeah.
I mean, I know that's a really not the greatest answer, but it's like, whoa.
But drastically different than what the studies would suggest, which is so interesting.
We also work in the subacute pain space, maybe not the chronic space, right? Because we're a car accident. So there's an incident and then we're dealing with them like 3 to 6 months from that incident, not chronic pain where you're doing a procedure and the patient's been in pain for 10 years and you're like, I don't know how much this may help. But I think that maybe there's something there, but I don't know that I have any data to support that other than saying if somebody doesn't get benefit, I'm pretty surprised.
Yeah, I mean, I think, man, there's so many things to like unpack here. I think that makes so much sense, right? That acute to subacute space, I think, is different, right? So I used to do that too when we were doing like sacroplasties and like kyphoplasties. And so we were noticing, we didn't pay as much attention to it, but like if you have an acute sacral fracture, right, the L5 nerves as they like traverse over the anterior sacral margin, oftentimes we can see if we really look, even on CT, there is some like perineuritis there. And so we were doing our plasties and people were getting relief, but a lot of people would still complain of radiculopathy symptoms. And then so we would do a steroid injection just at the time of sacroplasty. If we saw anything, we wouldn't just like blanket do it for no reason. But if we saw like a little bit of increased T2 signal or some perineuritis there, then we would do an injection. People felt so much better. But we would do these epidural steroid injections all the time, right? Or like,
Yeah.
and to try and target chronic radiculopathy, like if someone has a disc herniation or something in the spine and there's compression of a nerve, and then that can cause symptoms, that can cause, pain or shooting pain. And we would do a diagnostic injection with a local anesthetic to see if that pain got better. But then we would also give them steroids in hopes that that pain would then, go away for at least a couple months. And there's always variable results with that, right? And so I'm sure a part of that is the chronicity to it, and how like acutely inflamed that nerve is. So I think that's definitely part of it.
No, good.
No, I was going to go back to like the facet thing, actually.
Yeah. So to that point, so I have, again, this is a book here. This is the International Spine Intervention Society. Maybe it's backwards here, but this book, this International Pain Society, there is a physician in Utah. He's now going to be the president of the society, and he has been big about using PRP where we used to previously use steroid, and he's been publishing a lot. So I think within the next 5 years, I think we're going to have a big change in mindset about what PRP can be used for in the spine. So it's really, really interesting.
What's the volume that you're injecting into the epidural space? Or like, I mean,
so in the neck and for the audience, right? You think of the spine as a continuous space. The neck is tighter, the mid back a little less tight, and then the low back has the most space, right? But everybody's pathology is different. So you want to look at an MRI before you do an epidural injection, because you want to know, does your needle actually have room to get there? You want to look at different nerve structure. You want to look at their space. And then if there isn't, you want to probably target the level below or above and at least get medication somewhere near the target area. In the neck, I do 1-in-1. I'll do about 40 milligrams of Kenalog or 10 milligrams of dexamethasone, and I'll mix it with normal saline just to avoid high spinal, where if you put lidocaine or a local anesthetic in the epidural space near the well, you'll have to ambu bag the patient. So let's not do that. I'll have to call Divya. And then in the low back, I'll put about usually 5 cc's. So I'll mix it with a standard dose of Kenalog, 40 to 80 milligrams, and then I'll mix a little local normal saline. And patients usually do well. So there are different approaches. So that's the interlaminar, which for the audience is when you go in the center or a little bit off to the side. And then from the transforaminals, when the nerve roots exit from the side, then you can also inject on the sides. How I trained, I do about 1 to 2, maybe 3 overall mLs of fluid in the transforaminal injection. I don't do neck transforaminals often or mid-back thoracic spine transforaminals. They've fallen a little bit out of favor. In the mid-back thoracic spine, those injections like lung puncture, it's just a high risk. And so it just isn't as, you might as well just do the interlaminar and treat the pain. And then in the neck transforaminals, the vertebral artery courses where the nerve roots exit out. So a lot of the times, you're just very close to that vertebral artery, and so the injection just has higher risk. Where we see those injections is if a surgeon wants to figure out where to operate, and they're like, look, we just want a selective nerve root block in the neck. We want you to address the nerve root at this level and just see if it helps the patient, so we know where to. And so that's where we may see that.
How often do you do diagnostic test procedure before actually, this is like so unique to pain, I think.
Yeah.
Like most things, like if you have a gallbladder infection, you know that their gallbladder is infected, you just take it out.
Yeah.
But radiology, you can find all sorts of crazy things that don't correlate to that patient's actual pain. So is it always a diagnostic before the procedure, or 50%?
Great. That's such a great question. Next, it's funny, next week I'm giving a talk at a law firm, and it's about diagnostic testing and what we do, right? And I guess I best explain this. It's probably to think about back pain and neck pain and mid-back pain, kind of 2 different varieties. The first variety is for the audience, axial pain, so it remains in the spine, versus radicular pain following a nerve root from the spine down the arm or leg or wherever. And depending on the type of pain, we think about different procedures. If the pain follows the nerve root, we think about the epidural injection. And if we can reliably identify the level on MRI and physical exam, we try to correlate both, then we can just go to doing a therapeutic injection for an epidural injection, but really it's also a diagnostic injection. Because if they respond, you're on the right track, but you're also hoping that the steroid will help. So when you put numbing agent and steroid together, you have 2 phases of the response. The first phase is the local anesthetic phase. Are you getting relief almost immediately or for the next few hours? And then the steroid will take a few days to start to work. So you're going to kind of get two phases. In axial pain, where the pain is more midline, we think about the joints, the facet joints, and then you do the test injections. You do have to prove it because we know that MRI changes across the joints are actually insensitive to that. And I think the way I equate that is the facet joint itself, the joints in the spine are very richly innervated, but when patients get older, we get arthritis, it doesn't mean that that innervation is off or that arthritis in the joints or degeneration means pain. But when you have an impact injury in a car accident, you're essentially aggravating that capsule. And that's kind of how I equate to it. I don't always see MRI changes on the facet joints, but then when I do the exam, I see tenderness. I say, look, this is likely where I think it's coming from. And we do the test injection, and that can kind of prove it. And so for the epidural, we use imaging and physical exam to kind of help. But for the facet joint, we use the imaging just to make sure we're safe to put a needle there, but then use our clinical acumen to actually determine what level. So that's where the difference kind of in the nuance. The other thing is there's more culprits for back pain than I thought. So in between the spinous, so there's the vertebrae, the transverse process, and then there's a spinous process, the bone that comes off the back. And in between each spinous process at each level in the spine, there's interspinous ligament. And so sometimes on the stir sequences on the MRI, you can see the interspinous ligament edema. That was never used to be called when I used to send, referrals. But like now the radiologists that we use are more like radiologists who do injury reads. So they'll read it and a little more like kind of granularity, like for like a court case, like they're kind of reading it different. They kind of call these things. I'm like, whoa. And so we started doing injections into the interspinous, doing local anesthetic first, little steroid. They get relief. We can actually put PRP into the interspinous ligament, and people have really, really good benefit. But that pain is more midline pain. It's not going to go to the flanks like facet pain. It's going to stay in the middle. And so when I see young patients, it stays in the middle. There's no compression factor, obviously, any of that stuff. We say, the interspinous may actually clinically be what it is. And I've been right more than often. I'm like, oh, let me do an interspinous diagnostic, and voila, that's where the pain is coming from. So
it kind of sounds like you inject PRP regardless of the type of pain then, like whether it's axial, facet, or radicular.
Yeah, radicular is not as clear because we don't know the full safety yet, but for axial pain and midline pain, yeah. I think radicular, some people are doing it, but they're doing it on their own accord. Like not with the full evidence, but for facet pain, joint pain, we do it. For ligament injury, we do it. Hands down.
So the PRP injections, that can be perineural injections, or it can be in the joint, like the facet joint within the capsule. If the pain may be coming from pressure within the capsule, essentially.
Yeah. Yes.
Or is it all just perineural, or like what are you actually injecting? Is it just like a perineural injection, like a anesthetic and steroid? When you inject that, you're essentially injecting it around the nerve.
Yeah, exactly.
Is it the same target?
Yeah, that's a really good question. So I'm going to start with the facet joint. So here's a nuance thing, and maybe this is a really high level discussion, but we'll have it. So they've done studies, like I'm going to say, let's say the sacroiliac joint. The sacroiliac joint is the sacrum and the ilium joined together, and that has a lot of people have sacroiliac joint pain. It's a common thing. So they did studies where they looked at, so you put the needle into the joint for a sacroiliac joint. You're doing contrast dye. You're getting the contrast flow in the joint. But sometimes, for whatever reason, it's just tough to get that beautiful arthrogram. You want it to look really good, but you just can't. And it's more periarticular. Well, guess what? The results are the same for the injection, whether you're intra-articular or periarticular. It doesn't matter. The same thing with the facet joint. You can be in the joint and it can be perfect arthrogram, or you can be periarticular and the results are actually the same. And what I mean by that is what you're actually injecting is really probably around the facet joint, not actually in the joint, because in the joint's not where the pathology is. The pathology is in the capsule that holds the joint. And so that's what I think where the benefit's coming from PRP, not actually within the joint, because actually the patients where I get the periarticular flow respond equally, if not even better. And so there are some physicians I know that purposely do not want arthrogram flow for those injections. They want the periarticular flow because they know that that's what we're actually aiming for. For the nerve root, I'd imagine that it's just along the actual nerve root. And when you do the epidural, it's the same way. Like if you do a transforaminal epidural and you traverse the needle a little bit too into the nerve, they're going to feel it down the leg, and then you're going to make an adjustment, and then you're going to see the contrast, you're going to see the flow, and you're really just doing it around the nerve. But for the facet joint and for these joint pains, like this periarticular flow actually is really beneficial.
Yeah, that's what we found as well. At first, when like doing these injections, like we kept trying to get in the joint and right
Yeah,
down.
yeah. Let's get that perfect joint flow.
These cervical spine joints are so small, like the facets, and so to get your needle perfectly in that plane and to inject contrast is like really challenging. First of all, but two, it can be like kind of painful because you're disrupting that capsule, right? And but so then we would just get like near the joint and inject around it, and everyone felt great. It was always the same.
Yes.
So yeah, fascinating. But is that so? Then what are you injecting when you do like a large joint injection? Is it just the like the articular space?
Yeah, the space, just depending on what you're trying to target. So we can take the knee, for example. So in the knee, the approach I've done is actually suprapatellar rather than inframedial, infralateral. Partly because I think it's probably better that I don't touch the articular surface with the needle. Rather, if I do so if I look at the patella and I'm holding in the long axis, and then I go just north of the patella, and then I turn the ultrasound medial to lateral direction, then I can actually kind of visualize the quadriceps tendon. Then I look at the os underneath, and I can just guide the needle lateral to medial just to os and just dip it right up top, and then I'm into that suprapatellar bursa. That's a continuous space with the knee. And so I'm able to put PRP and essentially give it everywhere I can. Just put it everywhere. It's not like you're like, I put it in the shoulder. The shoulder we put, into the joint, we'll also do into the subacromial space. And sometimes we'll just do both because it's like, well, they have some partial tendon, well, they have a labral issue. Let's just put it into the joint under x-ray. Let's do a subacromial. Let's put the PRP in all this space. But the more granular you are, the better. So I'll give another example. I didn't realize you go to PRP. This is cool. So
we didn't either.
So I see patients now in more, and I'm sure you've seen this here with subscapular. So the rotator cuff has different muscles, and one of them is a subscapularis, which essentially attaches to kind of the medial border here. When there's a subscapularis tear, there's often an associated long head of the biceps subluxation, because they kind of work as like a pulley mechanism. And so sometimes we actually do a subscapularis and biceps tendon sheath injection for patients who have that particular issue, and not necessarily into the shoulder joint, but actually into that tendon sheath. And we've had good success. Now, when that pain is very mechanical and it subluxes out, like sometimes you'll get an MRI and there's no issue with the biceps. Well, was the patient moving when you get the MRI? Sometimes you do ultrasound and you can actually see the tendon come out as you move it. So that's an example of how ultrasound can also be diagnostic. And that's why we use ultrasound for PRP, because we can just visualize where we're putting all this. And so the biceps tendon sheath is one where, like, if we can be more granular, we can help a patient. And when you put in the tendon, you're actually micro dissecting it. Like, it's painful for the patient. Like, you're actually like trying to make it microbleed and put the PRP into the entire area that you can. And how much? I mean, in the shoulder, I'm going to probably put like 4 cc's in each, like subacromial space, 3-4 cc's, shoulder joint, 3-4 cc's. Bicep tendon sheath, maybe like 2-3. I'll kind of feed it around there. And then I'll go into the subscapularis if they have any issues. Now, if the tendon is completely torn, PRP is not going to bring that back. But with partial tears, 30% tears, maybe up to 50%, I would say. I have no track into why I picked 50%, but I would pick somewhere in that number. But if somebody has really mechanical symptoms, or the sublux, biceps tendon, complete rotator cuff tears without muscle atrophy, you want to have surgeons see that sooner. Once you have a tendon tear and you see muscle atrophy, then the surgeon's like, the decision changes. Sometimes there's also like a timing thing with getting these to a surgeon sooner rather than later. Or in certain cases, if you know you can wait, then maybe you have a chance for PRP.
Yeah, interesting. So you can really put this anywhere. So intra-articular, just like in a joint space, essentially, and then perineural around the joints. And then in the case of facets, I guess we're putting it around the joint space too, but you really could put it in the capsule too.
Exactly. And actually putting it in the joint is not even better. It's like you just do it worse.
It's technically harder and like potentially more painful, but yeah.
But it sounds like, so does it follow the same rules as for back pain, like where you shouldn't use it for radicular pain, like a shoulder injury with ulnar nerve distribution issues into the hand or something?
Yeah, I don't know. I don't know the answer to all the nerve stuff, where it goes. Because usually I'm putting in like a space. I'm not putting in along a nerve root per se. So I don't know. I think the jury's still out. I think if we have this conversation in a few years, I think I might have a totally different answer. And I need to get back to one of these conferences with the Spine, the Intervention Society, the International Physician, because I feel like they've made a lot of headway in the past few years. And the physician, I think his name is Zachary McCormick, and he's at the Utah. He's big into this PRP stuff. So he's been pushing, because we're trying to get insurance to help with it too, right? So I think that's kind of the push as well. And so I think the more we have, then the better. And I think the VA has actually started to like cover it for like the knee and things like that, right?
Yeah. The VA is big on it, actually.
Yeah, it
But
helps.
do we know why it doesn't help radicular back pain?
It can. No, it can help.
Oh, it can. Okay.
But we haven't established a safety. We haven't established like
It's
what
safety.
protocols, like is it truly safe to put in that space versus the articular space? Is there any kind of neurotoxicity? How is it? And the studies that have come out, they do like this 45-minute processing, triple spinning, like they have all these things that just aren't realistic for, like, I think, practice, where we need to see patients at a certain volume and we need to get through our day, and there's that aspect to it. There's realities of medicine, right? There's a financial aspect too, and we have to see patients in a timely manner. And so I think the jury's out, but I think there is benefit. I think they've shown that is benefit, and I think that's where we're going to see a change in practice, I think, in the next 10 years.
So
How
in
quickly-
current day, what are you doing for radicular back pain? Like, what's your management strategy?
Steroid injections. Oh, yeah. But there's other things too. I mean, they're more than just injections. I think when I think about back pain, I know it's ridiculous, but the biopsychosocial model, I think, is just the way I think about it. There's the biology of it. We've been talking about that. Then there's the psychology and social aspect. How are people processing their injury from motor vehicle accident? Is there PTSD involved? Is there other aspects involved that's affecting their response? And how are we going to, what's the social situation? Do they have any financial support? Do they have any family? What's going on here? Who is there to help them? And I think all of that matters too, as much as the injection. I had a surgeon who told me this when I walked in. A person's a surgical candidate when they walk in the door, not when you look at the image, not when you do that. When you actually just talk to the patient, if they're a surgical candidate or they're not a surgical candidate. And I kind of took that as like, wow, that actually makes a lot of sense. Like, if that they don't have the coping skills to deal with all the potential issues of your treatment, it's probably not a good idea to initiate that treatment if you can avoid it. Now, if you can't avoid it, they're in a massive accident, they have all these spine fractures, you have to do surgery, you deal with it, but I think there's like a conversation to be had in that space, and making sure patients use many tools in the toolbox. So in addition to the injections, and again, no financial relation to this book, this is called The Back Pain Book by Mike Hodge. This is an old book from the 90s. And what it does is it looks at all the different exercises, things you can do around the home, things like McKenzie-based exercises, which are extension-based exercises, but really McKenzie exercises for your back and neck can be tailored to the patient, because we want to go in the direction that does not reproduce your symptoms. So sometimes extension makes the symptoms worse, in which case you need to more have like a flexion-based program. So I think exercise is an important complement to the radicular pain. So we do a steroid injection, patient doesn't have a good exercise regimen, they don't have everything else maximized, they're probably going to have less benefit from the injection. And so I think it's a combination of what we try to teach and a lifestyle change, as much as it is like, oh, we have all these targeted procedures. Well, a procedure will help this aspect. Well, what are we doing outside of this, 15-minute experience?
So which of these patients do you actually end up referring to surgery for radicular back pain? Or are you always just injecting?
Yeah, that's a good question. Okay, so it depends on their physical exam. Are they myelopathic? Then we should not probably do an injection, or at least have somebody look. What does their MRI look like? Do they have severe stenosis? The narrowing is severe. Is it severe central stenosis in the middle? Is it on the sides? Is it at multiple levels? How old is the patient? What's been going on? What is their health history otherwise? Do they have a million comorbidities where a surgeon is probably not going to operate? Is there actual pathology for a surgeon to operate on? And I think I've learned from referring to surgeons and working with surgeons, it's like you have to have a question. If you don't have a question, don't send it. If you have a question, send it. And if you don't know, ask the PA.
The surgical PA or your PA?
And because I've become friends with all surgical PAs, and I mean that in the best way. It's like, if I have 100 questions, I'll ask a surgeon one of them. And I'll ask the PA, the surgical PA, the majority, because now that's allowed me to learn what I should actually be asking a surgeon and how I should actually approach that conversation. Because I'm very succinct. I'm like, look, this is an issue. Like, what is the answer to this single clinical question? And then I'm able to have a better outcome from that referral. If I send a patient in, they have moderate stenosis or whatnot, it's just not a good situation. Then they don't usually go for it or whatnot. But we really want the pathology to fit the MRI, and we want it to be at a severity level where it makes sense. And so that's kind of how I think about it. Or if somebody really has failed all conservative measures, I mean, sure, that's reasonable to send a surgeon. Time, medication, exercise, injection, all of that combination haven't helped. They've been dealing with this for a long time. Okay, it's reasonable. But if there's no pathology, then the surgeon is probably still not going to operate. But at that point, then at least you've maximized all the modalities. And if there are nuances in it, I always reach to the surgical PA. And if I have a question, I'll ask the surgeon. But I've just learned kind of when to pull that trigger. And I think it's helped me navigate these cases.
Okay, so I have a question for you. How often do you see MRI findings specifically for back pain correlate with patient symptoms?
Not that, like, probably like, if I get a percentage, like 30% of the time, like really not that often. It's about the physical exam, and that guides how you look at the MRI. Right.
Exactly.
Because, you're going to do an MRI read of Sheeter. You're going to find all the disc herniations. You're going to say, yeah, it's here. There's a bulge here. There's all this. And really the patient may have just been an athlete in the field. They may have been a jiu-jitsu, fighter, whatever is going on. And they have some previous thing. But that's at L2, and their radiculopathy is an L4 distribution down the leg, and they have a right L4 distribution. Well, the L1, L2 probably isn't contributing as much. And we know that the L4 herniation is. And so I think we have to tie it with the physical exam, and then that's how you target the treatment better. So in some MRI reads from hospitals, they actually give a whole percentage of, a lot of the findings you see percentage wise are actually within just normal people. And they're not sick.
Yeah. So, I mean, this is what I do every day, right? And I'll look at these spine MRIs and I'll read them. And I mean, really depending on the age, you can kind of guess what their spine's going to look like a lot of times. And so someone will say, okay, well, they're coming in for a radiculopathy here, or back pain. And sometimes I don't get a lot of specificity to it, but I'll talk about all these disc bulges. And then what do I write for that impression? I mean, I have no idea, right? I don't know what's actually correlating. And I'll see things that look incredibly severe, and I can like visually see impingement of an exiting nerve somewhere. I don't do this as much now, but I used to call and say, hey, do they have symptoms here? And like most of the time, no. Oh, that's not actually what they went in for. I mean, this part looks the tightest, this part looks the worst. I'm actually seeing the nerve being pinched here, and like there's no symptoms, right? Or someone will have severe stenosis at multiple levels and like totally fine, no symptoms. So then you don't do anything, right? But it's really, I'll read this stuff and I can't picture what you're actually seeing, because there's always a little bulge here, a little bit herniation there, some protrusion here, a broad-based osteophyte complex somewhere, but like I have no idea what that means for the patient.
And usually it does.
Yeah, I don't think it correlates.
And like I see patients with 2 levels severe central stenosis, axial pain, and the surgeon's like, I'm not touching that. Like there's no articular. Like, yeah, I'm not doing anything.
Care, right? Like they're fine.
I have a 90. I had like a 90-plus-year-old patient a few years ago, multiple level severe stenosis. She was skiing and she didn't care. Like it's just like, sure, like I'm not going to get surgery right now. It's kind of like we're at this. Yeah, I completely agree. It's totally about, does the symptom kind of match? And when it does match, then it makes sense. And maybe it's like something that could become like more sinister in the future, but sometimes not. And our spines degenerate, and it's a continuous space. This is something I didn't know. Like I kind of just have kind of learned this as I practice more. So it's like a continuous complex, a degeneration complex, where if you visualize a spine, there's the nerves that kind of flow in and out of it. There's the facet joints, the neuroforamen around it. Now you can have a disc herniation that pushes on the nerve root that causes an issue, right? Or you can have an irritation of the nerve root without a structural change, okay? Or the joints can degenerate, and the injury of the joints and instability can pinch a nerve root. So it's not just the disc, it's the whole complex that can pinch a nerve root. So is it the facets that are pinching it? Is it a hypertrophy of the facets? Is it that the disc is pinching the nerve root? Where is it pinching the nerve root? And so it's like the whole continuum that makes sense, because sometimes there is a neuroforaminal stenosis, but there's, stenosis more centrally. And so that's where the nerve pinches come. So that kind of nuance has also let me understand what is surgical and what isn't surgical. What is the surgeon trying to actually remove? Like, what are we trying to do here? Like, is it just the facets? Is it just the laminotomy? Is it taking out a whole portion of the bone? Does it need to be fused? What approach do you do? So they're looking at the MRI kind of through probably the lens of you, actually, like kind of that granularity of like, what is actually pinching here? So I think the back is interesting in that way. But even that we see all these changes in patients, like, I feel fine. Like, we're not doing anything.
Is there anything that would be beneficial to like, is there any part of the lumbar spine MRI or like any spine MRI where it would be beneficial to talk about more, or like in specific detail that you don't just see on baseline.
Like if somebody like were to have a finding and I want to talk about that more, like,
yeah, like is there something that I can talk about specifically that's actually helpful? Because so many times I'll read these spine MRIs. I don't know exactly what's happening with the patient, so I just talk about like random disc bulges here, and then the impression just ends up being like, hey, there's multi-level degenerative changes. Like, look at the findings pretty much on like where you think there are symptoms and see if there's something correlated. But I'm not going to put every single one of those obviously in the impression. But is there something that I can do to make that report beneficial?
That's a really
you
good
guys.
question. I think it's hard because we don't give you the history. I mean, like, if you don't have the history, then I don't. That's a good question.
Yeah, I mean, like the ones where I actually do get like, hey, left L4 radiculopathy, like I can look along the course of that nerve and tell you. But like,
I think that's the key. I think the more information we give you, then you're going to be able to look at exactly what we're trying to identify. But I think if you don't, then it's kind of, I mean, you'll have to say clinically correlate. I think, you want to look at the alignment, right? I think that's important. Like, is there any listhesis? I think that's important to call. I think that can be really helpful because then we can get a flexion extension x-ray. We can measure if there's any movement from the vertebral bodies. Does that make a difference in their care? I mean, a lot of patients have, and for the audience, these PARS defects where if you look at a specific kind of portion of the bone that can hold the different segments of the spine together, some patients just have a defect with wear and tear, or in life, if they were like a gymnast or did a lot of extension-based exercises or athletics when they were younger. And then in the future, they get a back injury and they actually have like listhesis, and then either it's unstable, so we get the flexion extension or not. And then that actually depends. Like if there's more than a few millimeters of movement, that's a surgical referral, because then the surgeon will be, all right, this is reasonable. There's movement here. What can we do to fix it? Because then an injection is not going to help with the mechanical instability. Now, if there's no instability, you can do a PARS injection. You can, kind of treat it from that standpoint. So I think listhesis is really important to call, whether or not because I think that can help kind of figure it out. But other than that, I think it's up to us giving you the history, and that way you can tell us what we want to.
Yeah, I think the alignment is super baseline. I think everyone talks about that. Everyone looks for PARS defects. Although, I mean, like, yeah, I think the only thing with the motion, you're not always going to see on MR, right? Like you could have neutral alignment on an MRI and still have some instability on motion because all MRIs are done in the supine position, right? So the patient's like laying down. And so they could stand up, and we'll see that sometimes, right? And then the alignment can change. And so they could have a normal alignment on the spine MRI. That's always something that we talk about. But then, it could be dynamic because we're only imaging in one plane.
You have, like, I've seen providers order upright MRIs of the spine and like different views. Does that have any value? I don't know the answer to that.
I have never read one of those, but I think that would be the value, right? Because when people walk around, the configuration of your bones, I mean, you're like, the spine is mobile, right? So as you're walking and you're bending and you're flexing, like the spaces are going to change. So you could have a pretty open neural foramen, but then if you were to move in a certain position, there could be impingement there. I'm not going to see that those dynamics on MR, right? I only look.
How many upright MRI machines exist in the world?
I don't even know if I thought that was like a real thing, or if I knew that was a thing.
Yeah, like I've had patients like, yeah, my provider like wants an upright cervical MRI.
I think that's why, because we're upright, right? So if that's maybe where symptoms are like most prevalent, I don't know, but like when you lay down, right, you could be opening a space. It just may not look as severe, but instability for sure. But I think that's why I think you just need to flex that plane fill. Like, I don't think you need a standing MRI. I think you just need flex.
Exactly. When you come into the ER, you get an epi. You're not going to get a flexion extension. You're going to get a 2-view. Or she's like, no way.
Yeah, man. There's so many limitations to what you can diagnose on these.
This is actually maybe the biggest question I get in the ER, right? Like all these patients come in with back pain and they're like, why are you not ordering me an MRI?
Right.
And that's actually the question. Like, who actually needs the MRI if only 30% correlate to findings anyway?
I mean, the only times that I feel like you can actually see something, it's like if you see a massive disc herniation in an otherwise normal spine, and it always ends up being a young person, like the 25-year-old, and they have like car accident, right? Something like that. Something acute happened, could be weightlifting, could be some sport injury, and then they have acute onset of like pretty severe radicular pain. And then their herniations they get like fecal sac stenosis. Like those are the ones that I feel like you can almost say this is an acute thing, or most likely an acute thing. Other than that, it's just all going to look like a degenerative spine. And there may even be an acute small disc herniation somewhere, but in someone who has background degeneration, like how are you going to tell?
It's difficult to identify. And then the lumbar spine and cervical spine are easier. Then you get the thoracic spine. It's a whole different ballgame. You don't really know. And it's interesting because in the thoracic spine, I had a patient with a giant T11, T12 disc herniation, but the symptoms were way higher. And so he had seen 2 surgeons and they're like, we're not touching that disc because it's not really, we don't think it's contributing. He ended up having facet pain. And I did like an upper thoracic right-sided facet radiofrequency ablation where I can burn the nerve root. So I didn't do a PRP in that instance, where I did a diagnostic injection across the mid-back joints, identified it, and then I actually place a needle and I burn the nerves off to those joints, called an ablation. So it works a little different than the PRP, where PRP kind of uses your body's self-healing properties versus the radiofrequency ablation can kind of de-innervate. But yeah, he ended up doing really great.
Yeah, I will say the other instance, and I'm not like advocating to get MRs for everybody, where I have seen, so we get like pan spine CTs on a lot of trauma patients, right? Where we will get a CAT scan of the whole spine. There are some vertebral body fractures that are really challenging to diagnose on CT, even in a patient that has normal bone mineralization. And for whatever reason, sometimes we'll get a follow-up MR and we'll find fractures that we didn't always find. But I will say, I still don't think that that's indicated, because all those fractures have no height loss. You're not going to do anything. There's no height loss. There's no like facet joint malalignment, nothing. There's no jump facets, nothing like that. So there's still nothing to do. I think the only thing that we're missing is, this is the etiology of their pain that we're not fully like revealing. But I mean, that is something that I do think that we're potentially missing, is probably some vertebral body fractures that can be really subtle sometimes. We can definitely see them most times, I would say, but occasionally I've seen a couple of follow-up MRs where really tough to see on CT.
And that's where, going back to like my space of motor vehicle accident, where sometimes the value is not just in what we can treat, but like identifying it for a case.
Yeah.
So
yeah.
you feel there
the
may be some value in the MRI, not just for the patient, but saying, well, what is it? Then sometimes we can get the MRI for that reason. Like, are we going to do anything? Maybe not. But at least then we've identified that there's maybe, something here that we didn't know before. So yeah, it's great. It's such a nuanced thing. I don't know, the spine is weird. I mean, there's just the things.
But all of those are like no height loss, right? That's why you didn't see it on CT. There's no retropulsion, like nothing like that. But they could go undiagnosed.
Yeah, no, makes sense. Yeah.
It's actually really cool. Like our 3 specialties are so different, but back pain is probably the most common unifying diagnosis for all 3 of us.
Yeah.
Yeah. I got an email from like the CMS or something like a few weeks ago or a month ago that basically they used my old job where I was like still billing Medicare. I don't bill any Medicare now, but essentially they're identifying low back pain and heart failure as 2 diagnoses. And then they're going to actually rate you compared to whatever scale that they have. And then the payments that you're going to get from Medicare are based on how you perform based on like that standard. So I think there's going to be like different changes in how we think about back pain and what we do, like as the insurance payouts kind of change and as these rules kind of change. So it's the most common diagnoses, but I just feel like things are going to change in the next few years, like with how the insurance looks, like, how people where the money is going to come from for these treatments and things like that. And so I think that calls into question, what is the value of an MRI? And when do we really want it? And so I'm always, now that I'm not in the health space, I really think about like, do I really need this stuff? What can it add for me?
Don't want to give Akshita money by ordering the MRI.
Yeah, I have way too many spine MRIs. Please don't order them.
Yeah, no. We get emails from radiologists that are like all the time, but we use a radiology center called Expert Radiology, and the guy's in Puerto Rico. This Dr. Avery, he's really good. He's really cool, and he has about maybe 25 to 30 radiologists. He was telling me that do injury reads. So they do he said 10% of the injury reads for the entire United States come through that practice.
Wow.
So he's very busy. But they read them a little different, actually. Essentially, it's like each level's like a little paragraph, and they have a nice summary, but it's like, and then at the end, they kind of summarize, well, based on the incident at this date, we think that these may be more the acute findings, and they have kind of disclaimers. So it's a little like different style of the reporting. I'm not saying one is better than the other, but kind of reading it to the types of clients that we see.
See, that's amazing. I mean, that's where I feel like radiology should be, right? Yeah. It's like reading it for specific scenarios. Yes. Like if you have a practice that is, accidents, right? Then reading it in that manner, but like as opposed to just general radiology reads for any lumbar spine MR that comes across. But that's where like it's beneficial when there is some connection there, right? And
Yes.
there is some conversation. And so often there is no conversation between the radiologist reading versus the person who ordered the study.
How cool would it be if you could, like, if you were in the ER or Neil's clinic and you could just pull the radiologist in and be like, hey, I'm thinking of ordering an MRI. Can you just do a quick exam and say what you want to order?
Yeah, this is what I wanted to do, actually. So when I was an intern, the radiologist was in the ER, right? And so we would go to
It
him
should be.
all the
Like, this is how
time.
medicine should be
I
practiced.
guess, okay, so no, to be fair, he was like a floor below, but whatever. He was there. And then we would go to him all the time and be like, hey, this is what's going on. What do I do? How do I order this? We would call him and we'd say, hey, this doesn't match at all. And that's what I thought I was going to do. I wanted to like sit in the ER and read cases and like sometimes even go see the person. Like today, I read a neck CT this morning and it said like palpable mass. And then so I like had my assistant call them and say, hey, like where is this? Like, what are you feeling? Like I need more words than this. And then so she sent me a message and she said, okay, so it's a right anterior neck mass, like underneath the mandible over here. And I read the scan, saw nothing. And so I called the ER and I was like I don't see anything. This looks like a normal scan. And she responded, she's like, oh, wow, thank you for calling. And then could actually explain it to me and was just like so grateful that I could look at it through her lens. And it's just not something that's feasible. We can't do this for every single case. And I think she was honestly palpating the submandibular gland, which happens so often. But I mean, like it was just like a little bit of peace of mind. Like I hate reading a scan where it says palpable mass as normal. Like there's it's just always clearly something, there's some disconnect. Something is missing.
Yeah.
If someone palpates something, I hate reading that as normal. That's so uncomfortable. But at least I could talk to her and she could really tell me like what she was palpating. I asked her if she thought it was a submandibular gland. She said that, yeah, that probably could be it. So like, I think we're pretty happy and comfortable there on both ends. But that's also got to be pretty unnerving. Like if you palpate something and then the scan says it's normal, like what is that, right? And oftentimes it's like physiologic lymph nodes or, submandibular glands. Like there are ways to explain that in a normal sense. It doesn't always mean that there's something off, but like it's just a lot more reassuring when we can chat and connect about that.
You guys bring up a great point. And Divya, to your point, like we don't practice medicine, I think, in a way where we're communicating. Like I had, when I was an intern, you guys know, so after we all went to medical school together, disclaimer for audience. And after that, we had to do internship. And so I went back to Buffalo. And in Buffalo, some of the older doctors, like I was at a hospital, were just people who I knew in the Indian community who were doctors. And they would tell me that back in the day, all the doctors would come have lunch. They would all be rounding and all the specialists, they all have lunch in the same room. And they would just talk about cases. They didn't have the EMR. They just all written records. So they would just talk. And they'd be like, well, what do you guys think of this? It'd be 3 of the specialists doing, well, what are we going to do? And so it would be like a little like board. It'd be like, okay, I'm going to do this. You're going to do this and you're going to do this. And they would just talk about each. And it was a lot more dynamic. It was a lot more fun. Like people would actually converse. But now it's like, I call a primary care. They're like, you're the first specialist who's called me in 3 years. I was like, oh, that is crazy to even think that that's the first thing you would tell me,
Yeah, I get that too. And that's wild. Like I'll call an ER doc and they're like, oh, I haven't talked to a radiologist in months. And I'm like, you order this stuff every day. Like, this is such a bizarre way to practice medicine.
Yeah,
like I sit in my house and I read scans and I have like no conversation with whoever is seeing these patients. And it's so bizarre.
It's become a
I mean, granted, I will say like sometimes it is not warranted. Like someone can order a scan and I'm like, yes, clearly like this is what it is. There's a fracture here. Yes, they have a hip fracture. Like I don't need to talk to everybody, but yeah, it's interesting.
Yeah, and I agree. But when I have these conversations again, I go back to, I still call the surgical PA. Like I really want to have a conversation, I'll call them. But yeah, usually it's not. Yeah, but it's I think conversations are good. I think it's interesting. Yeah. Wow. Yeah. I didn't realize we go so much into PRP, but yeah, it's cool. I think it really helps patients and just trying to get healthy for the best.
Yeah. I feel like we didn't even get into all the nuances.
There's so much more that we can talk about.
Yeah.
Wait, I still have a PRP question though.
Yes,
How quickly does it work?
Great question. So we do a 4-week follow-up afterwards. I would say response time is 2 to 4 weeks on average.
Okay, so it's not like a local anesthetic where you inject it and you're like, yes, this worked. Okay.
Soreness is normal, right? Because sometimes they're going to do the microdissection and then they're going to ramp up because it's recruiting the inflammatory mediators. People are like, I feel worse after this. And then after a few weeks, their pain starts to really go down. And so we don't follow up before a month because we're not going to know the time course of the response. Sometimes even a little longer. I did a PRP on a patient who had moderate arthritis of the CMC joint, the carpal metacarpal, and I did it under ultrasound. You can kind of see right into the joint. It's really nice injection under ultrasound. And then I put PRP, and basically after like 6 weeks, she forgot she had wrist pain, and then it kind of came back like a year and a half later, and she was like, yeah, I kind of just forgot about it. I was like, oh wow. But the response was longer than I expected. But truly, she had multiple steroid injections. Nothing else had ever really helped her.
Okay, yeah. So then those two follow-up questions, just like the steroid injection. So like, how long does it typically last, and how can you redo it, and how many times can you redo it?
You can redo it probably as many times as you want. We don't do it more than 3 times, just working with our financial claims and just kind of because it's expensive. I think repeating it, some practices, it is different. It varies. This is where the practice varies. So some will do like a booster PRP in a few months. I'm of the mindset of just repeating it when we need it. I think I always tell patients a good result from an injection is 3 to 6 months of at least 50% relief. If I can get more than that, great, awesome. If it's less, great. And I try to under promise and over deliver. So if I can get more than that, then that's really good. But then it comes back to, what are the patients doing outside of the injection that helps them? Are they doing exercises? Do they have bad habits? Do they have bad posture? Are they continuing down the bad road and the bad kind of habits? And if they're not, then I think these injections work a lot. But they're just not a magic wand. And so it's a very tricky question. How long it lasts, almost up to the patient as much as the injection, I think, to answer that question. But 3 to 6 months at 50% is great. And yes, you can repeat PRP. Steroid, you don't want to do more than, I think, 4 steroid injections in a calendar year, not more than 2 every 2 weeks in the 2 week span, and then looking at the clinical history, do they have diabetes, osteoporosis, like all these other things and history. So I'd say 4 a year, not more than 3 and 6 months for steroid. PRP, use it when you need it. Some practices for PRP that just do regenerative, there's practices that just do regenerative medicine. They do a bone marrow aspirate, and then 3 months later, they'll do a PRP booster injection.
Oh, interesting.
Bone marrow aspirate, then a booster after. And actually, they've had really good results for like up to like a year of relief and things like that. So it just depends on kind of what results you see and anecdotal evidence.
Okay.
Fire story.
Awesome. Okay, so you mentioned like exercises and posture, like anything prevention wise that you think people should think about or consider to maybe not have to get a PRP injection or a steroid injection or any kind of injection for back pain or an MRI. We don't want any of those.
I agree. And I actually have, there's an article I pulled up, just kind of I have it, I can send you guys with this American Journal of Lifestyle Medicine. And it talks about, again, the biopsychosocial model. I think that it just touches on all of that. Things like what pain catastrophizing, right? Like what are the behavior changes we can look at to help? Like how are we analyzing the situation? What are our behaviors that are leading to the pain, and how can we then modify that? And I think that's really important. I think things like Tai Chi, yoga, I think are also really important in kind of preventing back pain, improving flexibility. I think aerobic exercise can help. Now, it's tricky because weight loss doesn't directly as much help with back pain. And I looked into this more because I know I mentioned it to you guys before. And I think what it is like people do all this weight loss stuff and then they don't maintain it. You know, they don't do good things. Maybe they'll get off the medication, you know, they'll have surgery, but then they'll go back to kind of the bad habits. So I think weight loss does help kind of indirectly because you can move better, you can exercise better, but it's difficult to like study weight loss in a vacuum because like those patients just have so many other confounding things. And so it's not like a direct correlation with weight loss unless you see epidural lipomatosis on the MRI. Then weight loss can actually directly help with pain. And actually, amyloidosis.
That's what I was going to ask.
Yes. Oh, please go ahead.
No. Epidural lipomatosis in relation to weight loss. That's what I was going to say. Yeah.
Yeah. My understanding, it can absolutely help. And this conversation came up. I was at a conference and another pain physician who I know in the community was giving a lecture. He was asked, and he actually verified that epidural lipomatosis, if you see it and the patient loses weight, it can directly help with pain.
Yeah. So just to explain that
the weight of your body is causing the part, or at least exacerbating like the herniated disc or the axial load. So you're saying there is no correlation to like how much weight you are physically carrying correlating to pain? I think
it's just there's just so many, but like what do people do every day? Like how do they lift things? How do they move things around the house? Like, it's just, I think there is some correlation, but it's just hard to prove it and study it. But I think you're right. No, I think it absolutely, like, for me, it just makes sense. But when you study it and try to look at it, the data just isn't clear, because patients like skinny, like thin patients are just, they're heavy lifters, and they're just putting axial load on their spine from what they do each day. How do people sit in a car? Do they commute an hour? What is their posture in the car? And yeah, they may not be big, but are they also putting axial load on their spine? And maybe they lost 30 pounds the last year, but their sitting posture is so bad in the car that it's still bad axial load. So I think that's where, but I agree. I think there's some thought there. Even amyloidosis can cause stenosis in the spine. I was like kind of getting into those weeds, but so there are a lot of things that can cause it. But for weight, I think there is a correlation, but it's just hard to.
Yeah. But yeah, I just wanted to explain the lipomatosis thing. So the epidural lipomatosis, what that is. So when we have stenosis in the spine or other things that could impinge on the nerve roots in the spine that could potentially lead to symptoms, that could come from a whole bunch of different things. It could come from the disc that is like protruding towards the thecal sac or towards the spinal canal. It could come from osteophytes, which are like these bony like overgrowths that happen when we have degeneration. It could come from the facet joints, and then like hypertrophy of those facet joints. It could come from the ligament, which could thicken, and that's a ligament is along like the posterior aspect of the spine, and then that could get thicker and then cause compression. And then there's also something called epidural lipomatosis, where it's like increased fat deposition within the epidural compartment, oftentimes dorsally, so like towards the back, and then that causes external compression on the thecal sac or the area surrounding the spinal cord. So there's all these different factors. So it's not always like a disc herniating that could cause symptoms. It could be a whole bunch of things. And so what that means is we could treat it in many different ways depending on what's causing it.
That is exactly correct. Yeah, I think so. So to the point of what you can do to prevent, I think it's all these things, and I think things like diet are really important. Low inflammatory foods. I think just eating better, and I think you guys know this better than me. I think that really can help with pain. And the hope is that by having good mental state, by having good baseline exercise habits, by having good diet, you can actually prevent a lot of, the bad posture, the bad weight, and the things that can negatively impact the back. And what it does is it prevents, like, if you have an injury, you also have a better chance to recover. And I'm truly a believer in the mental aspect. We have a psychologist who works in our clinic who deals with patients who have PTSD or anxiety with driving after these accidents. And I think patients who actually respond well there actually also respond well to our injections. And I think there has to be some correlation there. And so I think there was a study where I think at least 70 to 75% patients who have pain over 6 months, 12 months have a depression and anxiety component that we can diagnose to the issues. And so I think it's cognitive behavioral therapy. I think all of these are just so crucial in preventing back pain from coming. And then looking at these books, like really understanding the root cause can be really helpful. We don't want to do injections. I don't want to do PRP. I would prefer not to. I'd rather see other things help. And medications help, but they don't prevent. Medications are reactive to pain. They're not going to help pain from forming, and so that's where we want to try to avoid too. And I think even things like gabapentin, we now know that has maybe long-term effects we didn't know about before. Cognitive decline later in life in patients who have been taking it long, especially when their age is 25 to 45. And so we want to try to avoid as much of that as we can. Just do everything else.
Yeah, awesome. I feel like that's a good segue into the walk me through your day segment.
Yes.
Before we do that, though,
I gotta go. So, do you want to keep going and I'll just drop off, or you want to wrap up fully?
Wrap up. I can do a quick. Is it just a quick day in the life, and we can call it? Is that what that be?
Yeah, we can do that. Yeah.
So, and thank you guys. I know this discussion went everywhere. So, okay, my day in the life. I'll get up. So I work Monday through Thursday, and I work 7:30 a.m. my first patient, 5:30 p.m. my last patient. So on Monday through Thursday workday, I get up at 5:15 to 5:30. I'll get ready, leave the house by 6 a.m. Takes me an hour to get to work. I have a hands-free driving, which is great. And then I get to work, and I just start writing notes immediately. I just keep dictating and writing. And then I see patients in 30 minutes to 60-minute windows, depending on procedures and follow-ups or new patients, or if they're foreign language. And then I work in a small room with my colleagues who are all awesome PAs, MDs. They are amazing colleagues, and we get along really well. I see my patients. I'm pretty good now about charting, so I'm able to finish all of my notes as I leave end of the day. Sometimes I spend about 15, 20 minutes afterwards, and I drive home. I spend time with baby, about an hour, 7 to 8:30. We put baby to bed. And then Prina and I just kind of hang out, and we live with our in-laws, so they're able to help at night because Prina and I work full time. On the weekends, I joined the local YMCA, so I do a few kind of workout regimens. I've been on a whole weight loss thing these last year, been down about 45 pounds this last year. So I've been doing just like YMCA, mixing different weights, working on the pull-ups. By the way, I'm working on that. So I'm getting there. I'm not there yet, but I'm getting there.
We are
We're not there yet either. We're going to get there together.
That's where I focus on the lifestyle kind of aspect of just incorporating consistent exercise, having a set schedule. And I think it's been really beneficial. And on my weekends, I try to just enjoy, spend time with as much as we can with my family, do some exercises, and kind of we have a really good routine. My wife, Prina, she is an attorney for the state, and she's able to work a hybrid schedule. And so we actually figured out. And on Wednesdays, I actually have my family drop me off to work. And then sometimes Prina and I do a date night in Renton. So we kind of mix it up. We have some date nights. We have spent plenty of time with baby. And I try to just incorporate being on the schedule and not bringing work home. And that's the biggest thing with my lifestyle. No work at home. Work is at work, and home is really at home. And being a father now has really, really changed. I don't bring work.
Amazing. That's awesome. I'm so glad. I didn't know you and Prina were doing date night. So very cool. Very cool. Very cool. I'm glad Ovi's doing well. And this was so fun. Thank you, Neil. Thanks so much for doing this.
Having me on. I didn't realize where the conversation would go, but I'm glad about PRP, and thank you guys again. Really appreciate it.
Thanks for tuning in to Dive into Health MD. Our goal is to empower you with knowledge to better understand how your daily choices influence your health. If you enjoyed this episode, consider sharing it and subscribing so you don't miss what's next. Please remember, this podcast is intended for educational purposes only and should not be considered medical advice. For personalized guidance, always consult your physician or a qualified healthcare professional. Wishing you physical, cognitive, and financial wealth. See you in the next episode.